Gentlemen, welcome once again to another episode of the Think Clinical podcast. My name is Hamza. Thank you once again for all the support. Please remember to subscribe, like, and share. We'll continue to bring you very exciting episodes. We'll continue to bring you some very thought-provoking conversations around healthcare entrepreneurship and building healthcare businesses. So today we are going to be looking at the myth around minimum viable products and why that fails in healthcare. Why we in healthcare you shouldn't be thinking about minimum viable products. And I know this will be an area of controversy because a lot of you would argue that minimum viable products are needed in every single field, and I will tell you what actually works or how you should be thinking about this in healthcare as compared to other launching other consumer products or other consumer businesses. So welcome back, and we'll be looking at this in terms of, first of all, what does it actually mean when we talk about minimum viable product. And in health tech, you are looking at just building the simplest version of your product that really delivers your core value, and then you release it to users. And after you do that, you learn from the behavior and improve it over time. So that's just what a minimum viable product is. So it works very well with consumer products because so a company like Dropbox started as a simple file sharing tool. Instagram started with just photo filters. Airbnb began with just air mattresses in a living room, right? And that's a problem. Healthcare isn't consumer art, so there are a lot of, again, as I've said in several episodes, the stakes are really high in the healthcare businesses. So that is something that we need to really pay attention to. And when you look at the numbers, according to research published by the Journal of American Medical Informatics Association, 30% of healthcare IT implementations fail completely, and another 50% underperform expectations. The primary cause is that we are rushing the products to market without adequate clinical validation. If you listen to my episodes, you would realize that I keep talking about clinical validation. And the translation here, in the midst of all this data, is that people are still thinking MVP in healthcare, in which case it really doesn't work. So in tech, minimum viable and it just means that it's good enough to be useful. That's basically what it means. In healthcare, minimum viable would often mean good enough to be dangerous. And if you keep this in mind, you would understand that the MVP mindset really doesn't work well in medicine. So a study from the Institute of Safe Medication Practices found that poorly designed e-prescribing system contributed to 770,000 medication errors annually. These weren't systems that failed completely. They were systems that worked, but just well enough to be deployed, but not well enough to be safe. So again, in healthcare, minimum viable means that it's good enough to be dangerous. That's what you should think about when you are looking at your products in that sense. Now, why does healthcare reject have-built products? Let me tell you what clinicians think when they hear something like an MVP. They don't think innovative. They think this could be a liability, either liability on them or a liability on the whole institution. So a survey of about 2,300 physicians published by Healthcare IT News found that 67% of doctors said they have abandoned digital health tools within 3 months of trying them. Again, this is because of the MVP thinking and the MVP mindset. The number one reasons the tool did not integrate properly with existing workflows. So again, the clinical validation conversation continues as we move ahead with some of these conversations. Number two, the tools felt incomplete and unreliable, and this is why most of them will reject or move away from them within 3 months. And this is what the MVP mindset in healthcare misses, because when you are looking at this, you have to make sure that when you're thinking MVP, do not miss the clinical workflow. Because once your product is not integrating very well with the clinical workflow, or it's not good enough, or it's good enough to be dangerous to the workflow that's already existent, people would not move away from it. So a study from the University of California, San Francisco tracked physician time usage. Doctors make an average of 94 clinical decisions per patient encounter. 94. They toggle between systems 4,000 times during a typical shift. So your MVP that just needs a few more features isn't a helpful tool. It's another cognitive burden in the already overwhelmed system that the clinician has to deal with. So imagine you have to make 94 clinical decisions per patient encounter. So clinicians don't have a bandwidth for like beta testing or anything. They need tools that work perfectly the first time and they work well every time. The part of their workflow shouldn't be trying to figure out whether this is really helpful or not. Secondly, what we miss is that half-baked integrations are worse than no integrations. So that's why the MVP system, MVP thinking doesn't work. So when you look at research from class, they analyzed EMR integration failures, and they found that partial integrations where data syncs sometimes but not always, or syncs correctly in some scenarios but not others, create more work than the manual process. Again, why? Because clinicians couldn't trust the system, so they double checked everything anyway. So it just made the work even more difficult than it was supposed to be. And the third reason why, and the third thing that we miss, is that patient safety doesn't iterate. So here's the harsh reality. In consumer tech, a bug means bad user experience. In healthcare, a bug means a death that could be preventable. So some of these things, we have to be able to think about them in the context of healthcare. Now, the difference between technical validity and clinical validity is important, and we need to be able to understand what the two mean. When we talk about technical viability and clinical validity, when we talk about technical viability, it means your product works as a software. That's just what it means. So it's technically viable. But when we talk about clinical validity, it means that your product improves patient outcomes. So your product could be technically viable, but not clinically valid. Or in other words, these two things have to work together for your product to be able to gain the level of traction that you need it to gain in healthcare. So when a study was done to evaluate 165 healthcare or digital platforms, 89% of them were technically functional, which means they were technically viable. 23% had evidence of clinical effectiveness, see the drop, and only 8% had evidence of cost effectiveness. So when you look at this, your MVP might work perfectly from a technical standpoint. It might be technically viable, but it might have a beautiful user interface, a clean code, and zero bugs. But if it doesn't improve clinical outcomes, which is the clinical validity of it, in a measurable and validated way, it's not a helpful product, and healthcare will reject it within the next 90 days if that doesn't come in. So what does clinical validity actually require? First of all, prospective clinical trials, not user testimonials, actual control studies with measurable outcomes. That's the first thing it needs. Clinical validity also needs integration testing in real clinical environments. Build a product, and based on you thinking technically it's a viable product, then it's going to work in the clinical setting. And the third thing you need for clinical validity is statistical validation of outcomes, not anecdotal improvements, not peer-reviewed evidence. Just you need to be not anecdotal improvements, but you need more of a peer-reviewed evidence that your tools really work. So, research from Stanford Medicine shows that the average time from digital health concept to validated clinical experience is 3 to 5 years, which is something that you need to be really looking at. So that's not slow. That's what we call responsible. So you have to be able to look at this. So what do we want to build instead? If we are not looking at MVP, so what will replace that? We will call it a minimum clinical product. And here's what that means. You start with the outcome, not the feature. So what outcome do you want to accomplish with the product you're building? So instead of asking what's the simplest version we can ship, you need to ask what's the smallest intervention that measurably improves clinical outcome. So again, MVP is now going to be an MCP, which is the minimum clinical product. And the reason is that you are starting from the outcome, not the feature, and you are asking two different questions, two different things that makes it different from an MVP. You're not looking at what the minimum product you can ship is. You're looking at the smallest intervention that is measurable or that measurably improves clinical outcomes. So you're still looking at it from a minimum standpoint, but they're looking at it from the context of a clinical outcome, right? So a brilliant example is the startup called Omada Health, which focus solely on diabetes prevention, and not diabetes management, not general wellness, just prevention. And that is a minimum clinical product because it's looking at an outcome, which is just prevention, and it's focusing on getting the validity and like measurable clinical outcomes just based on that outcome before. The second way to think about minimum clinical product is a prototype in simulation, and you have to validate it in reality. So you use simulated environments to stress test your product before clinical exposure. And the University of Michigan Medical Simulation Center has shown that products tested in high fidelity simulations have 60% fewer integration failures in real clinical settings. So make sure you expose it to that simulation environment. The third thing you have to look at is partner with clinicians as co-developers, not beta users. When you partner with clinicians and they feel a part of developing that product, they will work with you. And when doctors are involved from day one, not as consultants, but also as co-creators, you don't have to build an MVP and hope clinicians will adapt. You build a clinical tool that is viable from the start. Again, this has been another very exciting episode, and I need you to really reflect on some of these things that we talk about as you look into developing stuff in the healthcare space, especially if you're not from the healthcare business, and trying to understand how some of these things work. So build differently, validate obsessively, launch only when you trust your product with your own family. Thank you so much. Remember to subscribe, like, and share, and we will talk to you in another episode.